Bismillahirrahmanirrahim. We were discussing about coronary heart disease, and we came to know it is a demand supply mismatch. It may manifest because of atheroma, and it is a worldwide problem, and it may have different manifestations, and all conditions that are shown here are related to coronary artery disease and its complications. The deadly sequence of risk factors, atherosclerosis and CAD. Atherosclerosis is basically a widespread inflammation. Depending upon the artery involved, it can lead to a problem. It has 6 stages. The most final and dangerous fifth and sixth stage. It is an inflammatory disorder, as I already said, with inflammation, smooth muscle cells, plaques, unstable blocks or vulnerable blocks and stable blocks. Today we will mainly focus on atherosclerosis or coronary artery disease risk factors. So there are major risk factors. For example, age is the first, which is a strong predictor. Risk increases with age. Gender. Premenopausal women have lower rates of disease than men. There is maybe a protective effect of estrogen. Atherosclerosis runs in families, genetic, environmental, lifestyle factors, and positive family history is if a relative, first degree relative, male less than 50 and female less than 55 years old is affected with coronary artery disease, and this is a positive family history. Smoking, very much avoidable and has a dose linked relationship. The more a person smokes, the more is the chance of developing coronary artery disease. Hypertension, incidence of atherosclerosis increase with high blood pressure, whether systolic, diastolic, and pulse pressure. Hypercholesterolemia, increased serum cholesterol, more risk, especially LDL is high and HDL is low. The balance is disturbed and it will lead to coronary artery disease. Diabetes mellitus is a potent risk factor for all forms of atherosclerosis. Insulin resistance and glucose intolerance play a role in this. What are other risk factors? Physical inactivity roughly doubles the risk of coronary artery disease by 2 times. Obesity. Central truncal obesity is not good, especially, and it is an independent risk factor. Alcohol. Excess consumption increases risk of coronary artery disease. Diets. Diets that are deficient in fruits, fresh fruits, vegetables, and polyunsaturated fatty acids increase the risk. Hemostatic factors, platelet activation, high plasma fibrinogen concentration, and antiphospholipid antibodies also increase risk of coronary artery disease. Social deprivation amplifies the impact of all the established risk factors. A simple mnemonic: A for age, alcohol, B for blood pressure, C for cholesterol, D for diabetes and diet, E for exercise, S for smoking, gender, and social deprivation. So key points are risk factors have a multiplicative effect. It is a not additive. Okay, and absolute risk may not be equal to relative risk. Treatment thresholds should be lowered for socially deprived people. This strata of society should not be ignored in care, and they need it the most. So, how you so lifestyle modifications, no smoking, it is a population strategy. Avoid tobacco use entirely. Regular exercise more than or equal to 20 minutes, 3 times a week minimum. Regular exercise. Optimal BMI between 18.5 to 24.9 kilogram per meter square. A diet rich in fresh fruits and vegetables and limit the saturated fats. Fast foods, fried foods, it should be less than 10% of total energy intake. Adopt a healthy, heart healthy lifestyle. Smoke free environment, exercise regularly, eat a balanced diet, and decrease saturated fats to stay healthy. There are two strategies to prevent atherosclerosis in asymptomatic, but those at risk of CAD. Population strategy, as we discussed, we will modify risk factors in population through diet, lifestyle advice, and the rationale is small reduction in smoking, cholesterol, and a little increase in physical activity may have greater benefits. Some exercise is better than no exercise. You cannot outrun your calories. If you eat calories, you cannot outrun them. So better be careful with your diet. Benefits are that the risk of atherosclerosis and other related diseases like obesity and smoking related cancers will also go down if you adopt this. Individualized strategies are targeted strategies. Identify high risk individuals using composite scoring systems. We will discuss that later. Treat individuals with a combination of risk factors aggressively and properly. Consider absolute risk before initiating therapy. Do not jump onto medications immediately, but can be used for this purpose are antihypertensives and lipid lowering medications. What we assess in risk assessment, we evaluate for 10-year risk of coronary artery disease and a cardiovascular event, CVE abbreviated here. Consider treatment benefit versus potential risks, expenses, side effects, and probably long term compliance. So, here we compare two cases. There is a male who is 65-year-old and a 55-year-old female. Both are hypertensive, but the male is smoking, diabetic, having total HDL cholesterol ratio 8, LV hypertrophy on ECG or echo. 10-year risk is 68% for CAD, and cardiovascular event is likely to occur by 90% in this person versus the female who is same hypertensive but she is not smoking, she is not diabetic. Total HDL to cholesterol ratio is 6. Her ECG is normal. Her 10-year CAD risk is 14%. Her 10-year cardiovascular event risk is 19%. It is much less. So you can see that smoking and diabetes and cholesterol play a pivotal role here. So risk reduction here for the male would be to decrease cholesterol by 30% and blood pressure by 20%. and same risk reduction for the female. While treatment view is worthwhile, medications for the goals may be objectionable in unquestionable in case of the female. Other than for antihypertensives, we may not be giving her advice for lipid lowering therapy. So, case one is a high risk profile, smoker, diabetic with LV hypertrophy, high cholesterol ratio, and high 10-year risk. So, treatment benefits are more than risk. Risk to benefit ratio is more in the favor of benefits. But in case two, which is a low risk profile, who is a non smoker, non diabetic, and normal ECG, lower cholesterol ratio, lower 10-year risk, treatment benefit versus risk are answered. So, our take home message for today is absolute risk assessment guides treatment decisions. High risk patients benefit more from intervention, and low risk patients may not require aggressive treatments. So, this is the take home message. In the upcoming lecture, we will know how we risk stratify these people and how we know that it has a person has a certain 10% risk or 20% risk or whatever risk. So that is for the next session, and we will also address secondary prevention in that lecture as well.